Hi, so today's video is on hypertension and heart and hypertension. This video is mainly on heart and hypertension. There's another question which talks about vessels and hypertension. So there you will be focusing on the effect of hypertension on vessels. But in this question, you have to focus on the effect of hypertension on heart. When heart is affected by hypertension, we call it hypertensive heart disease, as you can see here. This hypertensive heart disease is a consequence of increased demands placed on the heart by hypertension. This hypertension can be systemic or pulmonary. It causes pressure overload in heart, leading to heart wall hypertrophy. So it so what happens is that hypertension could be systemic, that is, the vessels in the body except like other than the lungs. So we keep lungs and the body separately, and the vessels in the body, mainly the arteries, are affected with are suffering from increased blood pressure. Similarly, we have pulmonary hypertension, where vessels in the lungs, and majorly we are talking about pulmonary artery, is suffering from increased blood pressure. Both of these conditions cause pressure overload in heart. By that, I mean that, for example, if we take systemic hypertension, there's a lot of blood pressure in the arteries in the body. What will that do? That means that left ventricle has to pump against a lot of pressure against a lot of pressure to pump blood into the aorta, because aorta is a systemic artery and it has a lot of pressure, just like other arteries in the body. So that means that it has a high afterload, or it has to pump against a high pressure, and this is the pressure overload in heart that we're talking about. In case of systemic hypertension, we're talking about left ventricle. In case of pulmonary hypertension, we are talking about right ventricle. Okay. And both of these lead to heart wall hypertrophy. Heart wall, if it's systemic hypertension, it's going to affect left ventricle, and we will be talking about left ventricular hypertrophy. If it's pulmonary hypertension, it will be affecting the right ventricle, and we will be talking about right ventricle hypertrophy. When I say heart wall hypertrophy, I mean it's cardiomyocyte hypertrophy. You know, hypertrophy means that there's increase in the size of the cell. So all the cardiomyocytes increase in size, and that leads to overall increase in the size of the wall of the heart, or the respective ventricle that is affected by this pressure overload. And this hypertrophy is an adaptive response to this pressure overload. However, there are limits to myocardial adaptive capacity, and so persistent hypertension culminates in dysfunction, cardiac dilation, congestive heart failure, and even sudden death. Hypertension is a common disorder, that much you should know. Low blood pressure can cause inadequate perfusion of organs, leading to tissue dysfunction and death. Sorry for this like typing mistake. Um, so this is just a contrast between what low blood pressure does to the body, as you can see in case of shock, and like a circulatory shock, and what high blood pressure does to the body. It can cause end organ damage and is one of the major risk factors for atherosclerosis. WHO definition for hypertension is systolic blood pressure above 160 millimeters of mercury and or diastolic pressure above 90 millimeters of mercury. Causes of hypertension. So based on causes of hypertension, we can divide hypertension into two groups. First is primary or essential or idiopathic hypertension. It's often called essential hypertension, although it's makes more sense if you call it primary or idiopathic hypertension, because it's just more logical term. It's seen in at least sorry. So this is the majority of the cases. At least 95%, around 95% of cases of hypertension, of hypertension are primary. Both systemic and pulmonary hypertension, the primary causes are um, in the majority. As for the secondary hypertension, that means there's a disease in the body or disorder in the body which is causing this hypertension, whether systemic or pulmonary. But this is the minority of cases, as you can see, 5%. Um, to simply give you an idea, uh, primary hypertension, uh, when we talk about primary hypertension, because it's primary, it's idiopathic, we don't know the cause. We know certain risk factors which, if seen in which basically puts a population of people at risk of developing hypertension. And these risk factors can be are of two types: non-modifiable risk factors and modifiable risk factors. In non-modifiable risk factors, we talk about family history, that is genetics, age-related changes in blood pressure. So with age, whatever changes in blood pressure happen, right? Race or ethnicity. In certain, I think in Black Americans, there is just a higher prevalence of systemic hypertension seen. Um, um, Insulin resistance and metabolic abnormalities is also a non-modifiable risk factor. Under modifiable risk factors, you have high salt intake, obesity, uh, excess alcohol consumption, dietary intake of potassium, calcium, and magnesium. So for potassium, we definitely know that if it's low potassium intake, it has been correlated with there's evidence with hypertension. Whereas for calcium and magnesium, there's not much scientific evidence, but it's talked about. Another one is obstructive sleep apnea. So, similarly, there is some evidence, but not overwhelming evidence about its relation with hypertension. So, it's just something you can keep in mind. And as for secondary hypertension, what all conditions can lead to development of hypertension? So here we talk about renal disorders. Like, this is very important. You should definitely remember this. That a lot of renal syndromes and diseases lead to systemic hypertension development. It's not just one. There's like lots and lots of renal disorders that can present with hypertension. Um, Disorders of adrenocortical hormones, where we talk about aldosterone and uh, glucocorticoids. So here you have primary hyperaldosteronism and Cushing's disease or syndrome. I mean, Cushing disease and Cushing syndrome. So in all of these, you can again see development of systemic hypertension. Then there's pheochromocytoma. There is coarctation of aorta, and there is oral contraceptive drugs. Never forget the drugs. So oral contraceptive drugs are the most common cause of secondary hypertension in young women. Okay, so just remember this. Um, right, so systemic hypertensive heart disease is left sided, like we talked about. It affects the left side of the heart, left ventricle, and left atrium. Morphology. Um, so, gross morphology is that systemic hypertension imposes, we'll get to it. So, systemic hypertension imposes pressure overload on heart. This pressure overload, it's usually over long time. If it is over long term, it leads to structural changes in heart, because that takes time. It's not going to happen overnight. So this pressure overload causes gross and microscopic changes in heart. The essential feature of hypertensive heart disease is left ventricular hypertrophy, concentric type initially, and only much later in the disease process it becomes dilation hypertrophy. So pressure overload always leads to concentric hypertrophy, and only once the disease has progressed to like a much later stage, like it's really bad, only by then there will be dilation hypertrophy. It'll like lead to dilation of the ventricle and perhaps even atrium, um, and that usually ends up in congestive heart failure. It's like the heart has really lost, like the ventricles have really lost their ability to pump blood successfully. The heart weight can exceed 500 grams. Now, normally in 60 kg to 70 kg adult, it's 320 to 360 kg. Sorry, grams. I'm so sorry. This is a bad mistake. It's grams. It's not kg. Okay, but it can exceed 500 grams. The left ventricular wall thickness can exceed 2 centimeters. Normally, it's 1.2 to 1.4 centimeters. So you can see just how heavy and thick heavy the heart becomes and thick the wall becomes. With time, the increased left ventricular wall thickness imparts a stiffness that impairs diastolic filling and can result in left atrial dilatation. Um, because like it's the ventricle is not filling properly and the blood is like just backing into the atrium and like increasing the pressure within the atrium. Um, and then this dilation with time extends into left ventricle as well. So you have to remember, when there is pressure overload, the heart is trying to pump against it, which means that it starts thinking that its muscle is not strong enough to pump against that pressure. It starts building up that muscle. That's why we see hypertrophy, thickening of the wall. Um, but with time, when uh, well, it's not able to pump blood and the blood starts accumulating, it leads to dilation. So in long, sorry, and yes, and then this dilation, which was in the ventricles, with time extends into the, oh, sorry. And then this dilation, which was in the atria, with time extends into the left ventricle. So it starts in the atrium and it extends into the left ventricle. Um, So, in long standing systemic hypertensive heart disease leading to congestive heart failure, the hypertrophic left ventricle typically is dilated. So, all I'm trying to say here is that the uh, long standing systemic hypertensive heart disease, there is a dilated left ventricle, which is also hypertrophic, and this ends up in congestive heart failure. Microscopically now, there is increased transverse diameter of cardiomyocytes, increased size of nuclei and hyperchromasia, also called boxcar nuclei, and intercellular fibrosis. As you can see in these pictures, uh, this picture is basically gross and microscopic changes. So in A, you can see, so all of this is for left ventricular hypertrophy. In A, you can see the thick left ventricle from the pressure overload, how it's concentric. You can see this even better in B, which is like transverse section. So in B, the heart in the middle is the normal heart, And on the left, you can see concentric hypertrophy. And on the right, you can see there is hypertrophy, but it's dilational. Like, yeah, it's like dilational hypertrophy. On the lower images, you can see in C, this is the normal cardiomyocytes. This is how it normally looks. And D, you can see how big these myocytes are, how big the nucleus is. And it's hyperchromic. And yeah, we can see on the bottom this like pinkish area in between the cardiomyocytes is fibrosis. So it's actually a pretty nice picture. Um, yes. So pulmonary hypertensive heart disease called cor pulmonale. So cor pulmonale consists of right ventricular hypertrophy and dilation. What happens in cor pulmonale? What condition is called cor pulmonale? So process is that there's pulmonary hypertension, which is attributable to primary disorders of lung parenchyma or pulmonary vasculature. So it's primary, like I said initially, mainly primary. And this pulmonary hypertension leads to right ventricular hypertrophy and dilation eventually, often accompanied by right sided heart failure. So, when there's pulmonary hypertension, which leads to right sided heart failure, this is called cor pulmonale. All right, through the mechanisms I discussed earlier. Important point is that right ventricular dilation and hypertrophy caused by left ventricular failure or by congenital heart disease, it's substantially more common, but it's not called cor pulmonale. Cor pulmonale can be acute in onset, for example, if caused by a pulmonary embolism. As you know, pulmonary embolism is a cause for pulmonary hypertension, and it's acute, very acute. Like if it's big embolus, it is very acute, can be like exceptionally life threatening, fatal, and it can lead to cor pulmonale very fast. So that would be acute in onset. Or can have a slow and insidious onset when it's due to prolonged pressure overload in the setting of a chronic condition like chronic lung disease and pulmonary vascular disease, which is slowly leading to this um, pulmonary hypertension development and affecting the heart just as a result of that, slowly and not acutely. So morphology would be based on these. Acute cor pulmonale, the right ventricle only shows dilation. In fact, if an embolism causes death, sudden death, the heart may even be normal sized, like no structural change, because it's like it just happened so fast. There wasn't enough time for structural changes to happen. Chronic cor pulmonale. Characterized by right ventricular and often right atrium 2 hypertrophy. In extreme cases, the thickness of right ventricle can become comparable to or exceed the thickness of the left ventricle wall. By the time right ventricular failure develops, the right ventricle and atrium are dilated. That is, they undergo both hypertrophy and dilation. Like I said, just like left ventricle. Because chronic cor pulmonale occurs in setting of pulmonary hypertension, the pulmonary arteries often contain atheromatous plaques and other lesions reflecting long-term pressure elevations. Because, like, I think I said it earlier that hypertension has a very strong correlation with atherosclerosis. Okay, so someone who has hypertension has a very high risk for developing atherosclerosis. And so obviously atheromatous plaques, understandably. And all of this happens in chronic setting, not acute, chronic setting. In the second picture, in A, you can, so this is hypertensive heart disease, or heart looks like. In A, you can see it's systemic hypertensive heart disease, like we saw in the previous picture. The left ventricle is affected. You can read the, you can like read the lines below the picture on your own. As for the B, there here you can see, uh, co- yeah, it's like chronic cor pulmonale. That's why the structural, sorry, changes. I think the interesting thing here is that it doesn't look very similar to left ventricle hypertrophy. Right ventricle hypertrophy looks quite different. We can see that it's dilated and it's hypertrophied, but there is thickening of free wall, and you can see very, very clearly that there are hypertrophy trabeculae, which is not so obvious in the left ventricle. In right ventricle, we see this kind of morphology. The shape and volume of left ventricle has been distorted by the enlarged right ventricle. It almost looks like that the right ventricle is the left ventricle because it's like so big. All right, so that's it.